Yes.
Oh,
We can see
okay,
your
so
slides and we can see you as well.
okay, thank you. I'm going to continue the talk, the journey of immune check biomarkers, which is very nicely elucidated by Dr. Jasani. And PDL1 is the one of the most commonly used biomarker, and its role is very well established. But there are some queries that is it a reliable marker, or do we need to look for an for beyond this? And the TMB is the one of the most second promising biomarker for IO, which is coming up. So what is TMV? Is the tumor mutation burden, is the number of somatic non-synonymous mutations per megabase of sequenced DNA. And with the genomic analysis of various tumor types, it has been observed that there is a lot of heterogeneity in the TMV across various tumor subtypes. And there are some tumors like lung adenocarcinoma as well as squamous carcinoma and melanomas. They show a high TMV expression as compared to some hematological malignancies or tumor of kidney and prostate. So how how TMV can be used as a biomarker for the immune check for prediction of response? So the tumor which has high mutation burden, they can act like new antigens and which evoke the immune response. And it has been various studies across various tumor types, and the majority of the studies were done in the lung cancer, which have shown that a tumor which shows a high TMB levels, they show a better outcomes for immune check inhibitors. So that's why the TMV has been proposed as a very promising role as a biomarker in addition to PDL1, especially for the lung tumor. And so which tumors usually show the high PDL1 expression? The tumors which are usually deprived of potential targetable biomarkers, like if a tumor which is EGFR, ALK and ROS positive, the likelihood of being high TMV is low. But if there are multiple or complex genetic alterations are present, then those are the tumors which are likely to show high TMV. So in this which coming back to the lung cancer, the story of role of TMV started with this first publication in 2015, where it was shown that if a tumor has high high TMV expression, then irrespective of the PDL1 expression, there can be a better clinical outcome if the patients are treated with the immunotherapies. And then subsequent to that, there are multiple trials were started using TMV as a potential biomarkers, and they all most of them has shown very promising results with a very good OS and PFS. So that's why the PDL1 sorry TMV was proposed to be one of the more robust biomarker. But the testing of for TMV is also as complex as that for the PDL1. And this is very a nice article which has illustrated the potential problems or the areas where you have to be very careful. So similar to any other biomarker test, we have to be keep in mind about both the biological as well as analytic and pre-analytic factors. So the tumor type and the tumor heterogeneity also need to be taken into account, because there are some studies which have shown that even within from the different areas of the same tumor, or even from the primary and the metastatic site, the TMV can be different. So then which raises the question whether we have to rely on TMV at the primary tumor or at the metastatic site. There are variable pre-analytic factors which need to be taken into account when analyzing the TMV, especially about the paraffin embedded fixed tissue, because sometimes because due to the bonding between the bonds which form between the tissue, and due to the formalin, they can induce deamination artifacts and can result in the false TMV, high TMV. Next comes about which platforms to be used. So, and the panel size. That is one of the very crucial things when deciding about the TMB, and even further the bioinformatics pipelines which are used, and the cutoff for the analysis of these samples. So they are, all these steps are very complicated and complex, and so I'll just try to illustrate a few of them. So first is about the methods to calculate TMV. So initial evaluation was done based on the whole exome or whole genome sequencing, but that is not practical to do in the clinical setting. So what is recommended, now is thought that can we use the same panels which are, or the targeted panels which are used in the clinical diagnostic practice. So if your panel has a coverage for genes for more than 300, then it can be used, and it is proposed that for adequate calculation of TMB, it should be in the range of 1.2 to 2.2 megabase, and even the content of the panel and even the platform which is being used should be evaluated and considered properly. So why this panel is size is very important, because when the correlation with whole genome exome sequencing was done, so it was observed that the panel which gave coverage for more than 1 MB, that gives a very good correlation with the whole exome sequencing. So that's why your panel should be more in the range of 1 megabase, and this was observed. So if a tumor which has very high mutations, so in that scenario, even the variation among the various testing panels is not that great as compared to if there is low mutation burden. So even the various cutoffs was also used in various studies. So that again brought the same confusions which we have for the PDL1, that which criteria to be used or which cutoff to be used for TMB. As you can see there from these two tables, that there are there are various cutoffs was proposed, and the common cutoff, which is the common panel, targeted panel which is used in a clinical practice, is the foundation one panel, and for that if there are if it shows more than 10 mutation per megabase, it is proposed to be a high TMV. And if the corresponding number of mutation, if you see if it is more than 199, so then that case can be labeled as high TMV. And this is the table to illustrate there. In addition to foundation one, there are many other large gene targeted panels which can be used, and interestingly, if you see, all of them has a number of genes which are being tested of more than 300, and even the coverage is in the range of almost above 1 megabase. So interestingly, again, one point came out of this table. Even the foundation one medicine panel, although the total gene coverage is range from 0.8 to 2.2, but its minimum range is still below. So can we still, although it is commonly used, we can still use this panel for TMB, optimal TMB evaluation. Next is the reporting of the TMB. It can be either a high TMB or a low TMB, or there are some reports in which intermediate TMB is also reported, and depending on which system of reporting which you practice, also there can be a lot of variation in the cutoff points. After the panel and the analyzing sequencer, another important aspect which have to be kept in mind is about the bioinformatic pipelines which are used to analyze this data. Why it is important? Because the analysis for TMB need to be done only on the non-synonymous mutations. So, and there is need to filter out the synonymous and germline mutations, and TMV is further calculated depending on the VAF, variant caller, and the deduction of these driver mutations. So the bioinformatics plays a very important role. And finally, to summarize, the TMV evaluation is quite complex, and it need a very careful evaluation, right from the pre-analytic factors to the post-analytic and the bioinformatic pipelines. Just few words about the association of the TMV with the PDL1. So if the tumor which shows high PDL1 as well as the TMV, they are like the likelihood of response is much higher as compared to the cases which has both low TMV as well as PDL1 expression. But there can be some cases which, even despite of one being low and other being high, the response can be evaluated. So that means none of them are independent, although both of them are proposed to be linked to the immune check as a biomarker for immune check inhibitor, but the correlation between them is still not very robust. In addition, we have to keep in mind that in addition to TMV, there can be some certain other alteration like STK11. If this alteration mutation is present, then even the likelihood of response is low despite of high TMV. And as a lot of things are now being tried to be tested by using liquid biopsy, and same thing is coming for TMV. And there are some trials in which if it was proposed that if the TMV of in a blood is more than 16 mutations per megabase, then the patient can be treated with the immunotherapy. And the correlation between the tissue and the blood by some of the studies has shown that the positive predictive value of detecting TMV by blood is around 64% in one study, and other study shows around in 59%. So even this can be another promising application of the liquid biopsy for prediction of the response to the immune therapy. To summarize, the TMV, although it is a new kid in the block and which has its own pros and cons for use in the clinical practice, and it is full of its diagnostic complexity, limitation of sample resources and cost. And these are the summary of the challenges which we can face when we are trying to use TMV as a potential biomarker. And there are some of these are similar to that is observed for the PDL1 testing. And adequate acceptable sequencing panel size is one of the most crucial thing which we have to keep in mind, because many labs, although in India, are now doing NGS based testing, but their panels are usually of very small, and that will not give the information about the PDL1. So to conclude, although none of the biomarkers till date are very 100% reliable for immunotherapy, so we have to look for a combination immunobiomarkers for future for treating the patients with the immune check inhibitors. Thank you very much.